Hello, I'm Claire Williams from the European Lung Foundation, and I'd like to welcome you to this question and answer session today. Today's topic is Digital Health, a Brave New World, and this was a symposium given at the European Respiratory Society Congress in September 2020. I'd first like to welcome Dr. Omar Usmani, who is a consultant respiratory physician from Imperial College London and the Royal Brompton Hospital. And he gave one of the presentations in the symposium at the Congress. I'm also really happy to welcome today our patient representative, Rita Barriuso, and she's from the Asociación de Enfermos de Sarcoidosis in Spain. I'm also really happy to welcome Dominique Hamerlijnck, and she's a patient with severe asthma who also gave a presentation at the symposium on digital health and how it affects her treatment for severe asthma. So first of all, Rita is going to ask some questions to Dr. Usmani. She watched his session at the Congress and she's come up with some questions on the topics that he presented. We're then going to see a presentation from Dominique, following which Rita will ask some questions of Dominique about that presentation. So first of all, I would like to welcome Dr. Usmani and Rita.
Thank you.
So Rita, would you like to ask the first question for Dr. Usmani, please?
First of all, thank you for inviting me. Thank you, Dr. Usmani, for being available. And thank you very much, Claire. Thank you very much to ELF for this opportunity to interact with the experts. Dr. Usmani, we know examples about monitoring health digitally, like asthma, diabetes, migraine. Can you think about other feasible conditions to be monitored online in a short, medium period of time?
Yes, Rita, and yes, no, thank you, and thank you very much to the European Lung Foundation and to Claire. Yes, so digital has started embracing many aspects outside of respiratory, as you mentioned, Rita. So actually, telemedicine is now being utilized in Parkinson's disease, and there's also a lot of innovation in digital mental health. So understanding depression and anxiety via an app. And also in sleep apnea, there's a lot of remote assessment now being utilized in certain projects with assessing sleep apnea. And recently I was just reading about an app called Brian, which is actually from the Brain Tumor charity, which is essentially an app to help patients cope, those patients who've been diagnosed with a brain tumor. And I think what I want to show from the talk and the slide I've taken from the talk is there are two key components, I think, in digital technology and when you manage a patient with a condition. It's the monitoring element and also the self-management element, Rita. And I think these two things need to come together to give the best solution for managing a patient.
Coming to that, I wanted to ask you about how to combine e-health with a tech gap or the layer of society without access to digital media?
Yeah, no, that's a great question. And however positive we may be about digital, we need to appreciate those patients who may not have the access, the hardware, or indeed the software, the internet service to be able to engage. And there's no easy answer, I think, bar at the moment telephone consultations that are happening in order to make sure that there is a link that's remaining with our patients, certainly in the current pandemic that we are facing. But there is a lot of innovation in the digital side. So smartphones are being made available, certainly in low middle income countries outside of Europe, where they're being made cheaply in order to patients to be able to engage in a healthcare system, and internet systems are being provided. And actually, if we come back to innovation in Europe, and this is just an example from the UK healthcare system, where actually the term reimagining primary care is being used in digital asthma and exploring how healthcare systems can better use data and digital in the management of asthma patients. And there are many areas to look at, but we can highlight data sharing, a digital first in primary care, and again coming back to improving asthma self-management.
I was thinking about the elderly that maybe might have less skills with technologies, and I don't know what to think about this. Should we implement some experienced schools through, I don't know, the healthcare system, or what do you think about this?
Yeah, no, that's a great question. So actually, I think initially we all thought, well, will the elderly be marginalized with this digital innovation revolution, whatever you want to call it? But actually, studies are showing that elderly patients are really keen to be engaged, not because they have to be forced to be engaged, but actually willing to engage and willing to learn. So I think we need to start dispelling some of the myths that an elderly patient may not engage in a digital framework. But we realize that different aspects of different society may need different levels of support. I mean, we all required some understanding when we were engaging digitally, certainly by doing remote consultations where I am. So you're right, some form of support for them in terms of how to use the platform and how to use effectively when they are having a remote consultation. No, I'd agree with that, Rita. Some support is needed.
Yeah, I suppose that society is different in rural areas and urban areas. It's a difference between how elderly are engaged with technology. So let's move on to my third question, if you think it's okay.
Yeah.
Which kinds, levels, parts of the digital healthcare do you think are more likely to be implemented in the day-to-day practice globally in the short term?
Yeah, so what's happening to us all? Well, in respiratory, I'm not using my stethoscope anymore. I'm not doing peak flows with my patients in front of me. I'm not being able to send them off for pulmonary function test because it's aerosol generating. So I have my patient and I have my patient's head, and that's what I'm seeing. And as you know, as we all appreciate, Rita, 90% of communication is nonverbal. I'm unable to see how my patient walks into the room. I'm unable to see the rest of their body, how they sit down on the chair. So with the head, I'm having to be more alerted to how is their voice? How are they talking? Are their sentences breaking? And is that a reflection because their underlying respiratory condition may be getting worse, for example? Is their face flushed? And so one is having to adapt. And I think there's been a lot of innovation as well. So we now see companies are developing remote monitoring. So, for example, a remote monitoring of peak flow. So I think there has been a real change in terms of trying to adapt to the scenario. And you asked me the question. I think that you can divide them into two areas. It's monitoring and it's also teaching. So I'm using teaching materials now in my remote consultations, going through them with my patients, and then actually sending it to them digitally so that they can refresh and update themselves on teaching. And here's an example of inhaler technique, videos that we've undertaken with the UK Inhaler Group and Asthma UK. And interestingly, actually, if we look at this year, in the United States, this is a study for the first 3 months when they were under the COVID pandemic, in over 7,000 patients who had asthma or COPD and were having an inhaler tracker, you can see with the red arrow, there was a 15% increase in adherence. So monitoring and digital trackers have actually increased adherence. And why might that be? Well, maybe people have more time. Maybe initially people were thinking that their respiratory condition might be an underlying risk factor for COVID and therefore wanted to take care of their condition. But also they were concerned about engaging with primary healthcare and secondary healthcare. So they wanted to keep their symptoms under control and therefore were more engaging. So I think those are key elements in terms of monitoring and teaching and training, Rita.
Talking about training and talking about, you said before that you have to be extra, you have to pay extra attention to what you see in your screen. You learn all of this through your experience, and I suppose that should be taught to new students. So this new way of making digital health is something that future doctors are being currently trained in med schools.
Yeah, no, you're right. I mean, we're fighting against COVID with virtual consultations. So there is an etiquette isn't there, to remote consultations? And I think the societies, the medical societies are aware of this. So I've just put on the bottom from the UK, physicians, surgeons, primary care physicians, psychiatrists have actually developed best practice for virtual consultation, and recognizing that there needs to be an element of training, and what is the digital guidance, and what are the top tips for a successful video consultation. So certainly there is a need for individuals to be trained.
I suppose that we will get to a balance where we get to a combined attention, face-to-face attention, and digital attention, and that will be a reality globally.
You're right, and this relationship between the patient and the healthcare professional is really important. And actually, however positive we may be about digital, we need to think about the ethical implications. And so I've highlighted this in red circle in the slide again that I took from my talk. And there are moral responsibilities. There's a balance, isn't there, between the duty to do good, but also fostering patient autonomy. And there's a humanness and there's a quality of a care that we need to really think about, and importantly, trust and confidentiality. And I know, Dominique, you're going to be talking about trust, and that's something that's very dear to you in terms of your experiences. But Rita, we need to really think about the ethical implications as well.
Yes, of course. And I think that patients are also very concerned about how their data are managed. And it's as time goes by, they're more aware about how data is sensitive material. And they are more aware about that. But well, I think that trust, that is something that we are going to speak later too, is something that we need to build. Also, a relation of trust between doctor and patient, and it's a must, is a real must. Thank you very much for all your answers, Dr. Usmani. It's been very useful and so enlightening.
Thank you very much, Rita, and also thank you to the European Lung Foundation for the invitation to chat.
And thank you both for joining us and for giving up the time today. That's been really helpful, and I think with the pandemic as it is, I'm certain that we will see an increase in digital health going forward into the future. So it's a really important and a topical topic, I think. I'm very happy now to welcome Dominique Hamerlijnck. Dominique's from the Netherlands, and she's an expert patient who gave a presentation at the symposium talking about her experiences of digital health. We're going to watch that presentation now.
Good whatever part of the day it is where you are. I have the honor of being the first speaker at this interesting symposium on digital health. The last months have shown how fast things can change in health and how fast digital meetings between patients and doctors could suddenly be realized. I am going to share some of my reflections on digital health. These are my conflict of interest. For me, one of the most important aspects of the patient-doctor relationship is trust, and my talk will mainly be directed at trust in a digital and non-digital health. Going forward in the digitization of care, a vision is the replacement of the doctor by algorithms, a digitalized system that gathers the information indicated and gives the solution to the problem. Basically, guidelines are a form of algorithm. They guide the doctor and patient to different questions and offer diagnosis, management, treatment, and prevention options. This is fine, as it guides the thinking and the questions we need to ask ourselves when deciding between doctor and patient what would be the next step forward. However, most of these guidelines are based on averages, on what is most common. I am a good example of where just looking at averages would not help. My severe asthma does not make me wheeze, and I very seldom cough. This has made my life and care quite difficult. Too many physicians followed the guidelines too strictly and told me I do not have asthma, did not know what to do with my treatment and care. This is where the doctor's and patient's experience and intuition becomes important, and guidelines are there to guide us, but should not replace or take away from the knowledge and experience from patient and doctor about a specific patient's condition. Developing algorithms based on guidelines and research has the added problem that we do not know or understand the system behind it. This leads to many problems, as we have seen, for example, in the banking crisis in 2008. Nobody understood the algorithms, and they created a lot of problems and made the financial world shudder on its foundation. But even more importantly, nobody knew how to correct the consequences either. Trust and the process of evaluating and correcting is needed in algorithms used in care. In the past decades, the patient-doctor relationship has changed for the better. We are becoming more used to treatment options being discussed between patients and doctors, having a conversation about what the patient feels is going on, looking at both signs and symptoms. The relationship between doctor and patient is becoming more and more based on trust. I, as a patient, feel that I can trust my doctor with my most precious possession, my health, especially when it is already compromised by one or more conditions. Though there is nothing wrong with having a doctor-patient consultation via a digital system, trust is built better in face-to-face meetings. Nonverbal communication, which comprises around 80 to 90% of human communication, works better in a face-to-face meeting, and that helps to build trust. Even I, who am used to having digital TCs, find that there are issues I prefer with my doctor in a face-to-face meeting, especially when I'm worried. I'm not sure what's going on, when I feel something is not right, but don't know what. Recently, the Dutch Medical Board has reinforced the importance of intuition of both patients and carers when something is wrong. Exploring this is something best done face-to-face. It does not mean that we should only have face-to-face meetings or only digital meetings between doctors and patients. I was very happy during the COVID crisis that I could talk to my doctor through a video link, but I had things I kept to myself until I could have a face-to-face meeting. I hope I have given you some food for thoughts for the future.
Okay, thank you. So now Rita is going to ask 2 questions of Dominique about the presentation. Rita, would you like to ask your first question?
Yeah, first of all, thank you very much, Dominique, for being here.
You're welcome, Rita.
To be available to us to answer some of my questions. And my first question is that I completely agree that a combined face-to-face attention and online consultation is the best formula, but we need trust between the doctor and the patient. But what to do when this trust is not solid or is not there?
Yeah, that's very difficult because basically a doctor-patient relationship is not really an equal relationship, and that's something. The doctor is the expert, and you have your own expertise on the disease, but that's often not recognized. And what I talk about in my presentation is that I do have trust with my present consortium of doctors, but it has not been an easy travel because, to give an example, I've had 6 lung specialists who told me I can't do anything for you. So that's an absolute breach of trust, and that puts you as a patient completely with your back to the wall, which I think they don't really realize enough. And what I've learned from this whole process is, on the one hand, you have to be lucky. You have to find, it's silly, but it's true. You have to find a doctor where there is a match and where you can build on this trust. I do feel that you, as a patient, you can do some things to improve the trust. And one of the things, though it is sort of counterintuitive, is when I feel I'm not helped enough, I try not to attack them, but try and keep asking open questions like, okay, you tell me there's no drug for XYZ. Is there anything else we can do? Hey, you think I don't have asthma? What could it then be? And how shall we then treat it? And so these open questions can also change the doctor's perspective from, they have, I don't know how many patients a day, and every 10 minutes someone else, and try and see you as a person, which is almost a necessity to build the trust, to not see you as a number 25 in this week, but see you. And unfortunately, or fortunately, because it can help, you as patients can have this impact to without attacking, start asking the open questions. And that's also a way in that you support them in telling them, I want to hear from your expertise, which is always a good place to put them.
Yeah, not attacking them, but asking them to, what do you think if, yeah, I understand.
What could be helpful, what could, and I also think it's, don't shy away from emotion. Don't shy away of showing them that you're really at the end of your tether, that you're really sort of, you don't know where to go anymore. And especially, it's not getting angry at them, but showing them that this is really frustrating, and this has such a big impact on your life, and because that helps them put it in perspective.
Yeah, completely agree. But sometimes it's so difficult not to fall into despair when you are in that point, and don't get frustrated, and you know, turn that frustration into anger, and turn that anger through your doctor. That is the only person that can help you. And I know it's like you know, a ninja star throwing your anger to the doctor, or a boomerang, because it's more an example. You throw your boomerang to your doctor, and then your boomerang goes back to you. But yeah, I think do you think that we can think about some kind of managing school to patients, how to speak to your doctor, how to communicate to your doctor, how to have an effective communication with your doctor?
Yeah, I think there are no solutions that will work everywhere all the time. And you still will meet doctors that, and like what I told you about, 6 different specialists told me, you don't have asthma, I don't know what you have, can't do anything with it. That's sort of the end of that relationship. But I think there's some things we have done in the past is you have the clinical guidances. And what we worked on, for example, in the Netherlands, and I know other countries did as well, is to translate them into sort of standard of care. And what we also did in the Netherlands, and I think other people did as well, is then sort of based on to create a patient guidance on how can you prepare when you go and talk to your doctor, sort of think about what are the symptoms and the signs that are the most bothersome. Where is your frustration? What's not working for you? So that you sort of, in that way, also sympathetically remind them about what they're supposed to do, but also give them the information on what's going on with you and where you need help. And the help isn't always there. We all know that I have severe asthma, but not the eosinophilic kind. So the standard medication is what I need to deal with. I'm not. I can't go into the biological treatment and anything, but it's good to keep reminding them and keep on asking, and that helps really well if you use these questions to prepare for the 10 minutes or the 15 minutes you have with your doctor. You will have a better conversation. And you might not get all the answers, but at least you've done something positive yourself.
Yeah, agree. You feel better.
Yeah.
Yeah, completely agree. And I need an advice from you, talking about this trust from your experienced patient perspective. What can we do when this trust with your doctor, after you said I had 6 doctors that weren't working, let's say, our relation was not good. After trying and trying, that trust is not there. It's not working. What can we do?
Find another one.
Okay.
It sort of depends, and I think something I have learned, and I also hear from other patient experts, it's good to remind yourself that doctors have a mindset that they want to help, they want to give you a drug, they want to do something real to help you further, but quite often there isn't anything they can do. And everything that can be done is being done, and it's not helpful. It still leaves you very frustrated. Aspects of your disease are not addressed. This is sort of educating your doctor in just supporting you. I had a conversation with my primary care physician this week, and she said to me, literally, Dominique, what I have learned in our last 2 talks is that you are a patient expert. You know a lot about your disease. And for me, that is a pitfall that I don't really look at you anymore. That I forget that there's still a lot of stuff going on that you might not know about. And like I said in my presentation, there's things, what the hell do I know what's going on? I'm not sure what's going on. So that's hard to talk about. And I think by sort of telling her, thank you for saying that, or just telling them, just showing that you see my suffering sometimes is already very helpful. Yeah. We both know there's nothing we can do, but just that you see that I'm suffering and you acknowledge that we have nothing to do. It took me a long time to get my lung physician to acknowledge there's nothing for that part of your asthma. We don't have anything. And I think that's something they've sort of unlearned in their training, and we as patients can teach them that already is being helpful because you show that you see me as a person. It's changing the perspective from the disease with a person in the back to a person with a disease. And I think that's what we need to achieve.
Yeah, it's difficult to get to that point. And from time to time, we as patients also have to be in the shoes of the doctors.
Mm-hmm.
because that's something we do not practice very often. And we have to think that they're doctors, but they're also people. And we are always complaining, my doctor doesn't understand. But your doctor is also a patient, because he's not only a doctor. From time to time, we patients seem like 3-year-old that doesn't understand. My uncle is my father's brother, and we do not understand. My doctor is also a person, is also a patient sometimes. And we have to make this exercise to get in the doctor's shoes and to think, this is a person. And it's a conversation I had with my PAC also. I was saying, don't you think doctors sometimes when they're having these presentations are too clinical and too excessively treating patients as data? And then they told me, Rita, they're also people, and they're speaking, giving data because that's what they are supposed to do in that moment. But if you get and approach them, you will see you can speak to them, and they're people like. And I think that we have to be a little bit more in their shoes and help them be a little bit more in our shoes. I don't know if that's...
I think you have to be careful as a patient not to go and stand in your doctor's shoes, because that's not where you want to be. But I completely agree with you. I actually said to my doctor a year ago, I said, this is bloody frustrating. I can imagine how frustrating it is for you to see me suffering and not be able to do something. And that sort of broke her way of looking at me as well. So the way we can interact is we can give them the option to become more human as well, to not just be the white coat person, but also be the whole person. And they have a different responsibility than we have. And that's where we have to find the point where we meet. We have, as we always say, we have our expertise about our disease, and they have their expertise about our disease. And we have to match those, because both of them are incomplete pictures. And only when we can find a way to bring them together, we can get understanding about the whole picture of the disease.
I was speaking to Dr. Usmani before, and we ended up. I ended up telling him my conclusion of this e-health of Brave New World. Maybe we are not in this point right now, but maybe some time we will get to this combined digital and face-to-face consultation, and that will be our day-to-day reality. Do you think we will get to that?
I'm of two minds. I think we will get to that. I hope we will get to that. And I think if well designed, and that's the second mind, because so many e-health applications are badly designed, have absolutely no added value to the patient, and don't bring anything to our understanding and how we can manage our disease on a 24 hours a day, 365 days a year, as it changes all the time as well. I think it would be very helpful, because we as patients would add information and knowledge to what the doctors have, because they don't know what we do on a daily basis. And by discussing it, we can also bring together what they would need to, and what outcome measures are really relevant to measure through an e-health app, and where we can then have simple consultations or simple exchange of information saying, I was involved in developing one for COPD, where it was simply sort of the doctor checking, is this patient, or the nurse checking, is this patient in the green area, orange or red, and acting accordingly. And that's what needs to be included. It's not just us putting information in there and the doctor yes or no, or the nurse yes or no checking it, but it needs to be a two-way street. And I, by example, now use an app to keep track of my asthma control. And suddenly I was phoned by the nurse, the hospitalist. But that was because I was scoring really, really bad. And I thought, this is when it works.
Yeah.
When somebody is checking what's happening with this patient, do I need to organize a consultation with the doctor? What conversation can we have? Because in the end, only that way we can improve how we can control our disease and their knowledge of how to control our disease. And then it will have added value.
Yeah, and I suppose that it's also connected with what Dr. Usmani was saying, that it's self-management and digital part of the e-health applications. You can have your application and it could be wonderful, but if you are not managing it yourself, there is no point. You cannot add your data, you cannot check yourself. And if you are not adding that data, it's not point. So.
Yeah, and I think one of the dangers is that this is not available or applicable to everybody. Not everybody is able to develop this sort of insight into their disease, to be able to add, even if they're simple questions, it's for them sort of taking their day-to-day experience and translating it into a score is something so far outside of their comfort zone. And I think it would be good to develop the apps or other systems that can be used by patients that are more insecure, less digitally savvy, worse in reading, because it requires a lot of reading skills as well and language skills. And I think actually research has shown that approaching it in a different way can be easily solved for patients who require different types of communication. But that's a part that's underdeveloped still.
As we have different communicative styles, I suppose that they have to maybe develop different levels of skilled patient approaches to this kind of applications.
Yeah, and it could be as simple as, instead of putting the question out there in a written form, you could have somebody reading it. And we had some research done where, by example, for informed consent, if somebody just reads it like a news reader, so it doesn't have to be fancy, it doesn't have to be complicated, talks about the content, that already helps a lot of people to understand it better, to have the written and the spoken variety. And sometimes, like with children, have it in cartoons or whatever. There's so many ways of communication have already been developed that somehow get forgotten in e-health development.
Yeah, and accessible too for disabled, and
yeah,
sky's the limit, I suppose.
In a way, yes, but that requires creativity, and that requires that patients are involved and that they're listened to, and that the technical people really listen and translate it, because quite often that's where problems start.
Sure. Yeah, I agree. Thank you very much.
You're welcome, Rita.
Thank you, Dominique.
Thank you for taking the time to ask these questions after my presentation and listening to it.
Thank you for your presentation and thank you for answering them. And thank you very much, Claire, for arranging everything.
Yes.
Thank you both for giving it your time today and for such an interesting discussion.